Imagine looking at a patient, right, and their neck is actively weeping fluid from this tiny pinpoint hole just above their collarbone.
Yeah, that is definitely not something you see every day.
Right. And would you guess that you are actually looking at like an abandoned anatomical tunnel, a microscopic construction flaw left over from when they were a developing embryo?
I mean, most people certainly wouldn't.
Exactly, because medical diagnosis is rarely as clean as, say, a jagged white line on an X-ray. It's chaotic, it's messy, and it relies entirely on a clinician's ability to recognize patterns in, flesh and blood.
It really does.
So, welcome to today's deep dive. We are talking directly to you right now, whether you're a medical student staring down the barrel of your board exams, maybe a young professional brushing up on your diagnostic skills, or just an independent learner who's fascinated by the hidden architecture of the human body.
It's a fascinating topic for anyone, really.
It is. And our mission today is to unpack this phenomenal resource. It's called Image-Based Case Studies in ENT and Head and Neck Surgery. And it was written by Dr. Ramat Omar and Dr. Prabhadran Narayanan from the University of Malaya.
And, what these authors have achieved here is essentially a masterclass in clinical exposure.
Yeah.
They've curated 124 distinct clinical scenarios, and they rely really heavily on visual cues that span from like the microscopic debris of the inner ear all the way down to the vocal cords of the larynx.
Which is incredible. We're going to take you on this transition from passive reading, to staring at text on a page, to active clinical pattern recognition.
Right.
We'll be providing a really comprehensive, scientifically rigorous summary of the core lessons in this text, looking at the actual mechanisms behind the diseases. And definitely stick around because we are culminating this deep dive with a rapid-fire clinical review exercise.
Yeah, a little test to see how well you synthesize the material.
Yeah.
But before we jump into the specific pathologies, understanding the architecture of this book is vital because the structure itself dictates how a clinician learns to categorize information under pressure.
Okay, let's unpack this.
Yeah.
Because the authors basically divide this vast landscape of otorhinolaryngology into 4 distinct pillars.
Right, 4 sections.
Yeah, so you start with otology, which covers the ear and temporal bone, and that's in questions 1 through 43. Then you move into rhinology, the nose and paranasal sinuses, which takes up questions 44 to 76.
And then it moves lower.
Right. Then it's head and neck cases. So that covers everything from salivary glands to thyroid masses, running from 77 to 102. And finally, laryngology, dealing with the throat, airway, and vocal cords, wraps up the text from 103 to 124.
It really operates essentially as a flight simulator for medical professionals.
Oh, I love that analogy, a flight simulator.
Yeah, because it drops you directly into the consultation room.
Yeah.
You handed a photograph of a patient's distorted anatomy or an endoscopic view of their sinus cavity, and the clock just starts ticking. You're forced to observe, deduce, and act based purely on that visual evidence.
Which really reflects the reality of the job. I mean, Vice Chancellor Goth Jasmine notes in the foreword that a picture paints 1,000 words.
Absolutely.
And in the clinic, a picture might save a life. Because these are not, idealized textbook illustrations. They are unpolished, real-world presentations.
And this raises an important question. How does a student actually make that leap?
Right, from the textbook to the patient.
Exactly. Transitioning from a bulleted list of symptoms to recognizing a pathology in a living patient, who might present atypically, requires bridging a massive cognitive gap.
It's totally different.
It is. The answer is iterative visual exposure. You have to train your neural networks to see the relationships your brain has only theoretically understood up to that point.
And case 85 from the head and neck section perfectly illustrates how complex those relationships can be.
Oh, that's a great example.
Yeah, so a patient presents to the ENT clinic with a seemingly localized issue, right? Bilateral parotid swellings. Basically, the major salivary glands in both of their cheeks are massively enlarged.
Which is a standard presentation that might tempt an inexperienced clinician to focus entirely on the jaw and the neck.
Right, like just look where the swelling is.
Exactly. They might start ordering local imaging or consider, a localized infection of the salivary ducts.
Yet the critical diagnostic clue is nowhere near the face.
No, it's not.
The text shows the clinician asking to examine the patient's hands, and the visual provided reveals these classic finger deformities. swollen, misaligned joints that are characteristic of rheumatoid arthritis.
Yes.
And by connecting those arthritic hands to the swollen cheeks, the diagnosis just clicks into place. It's secondary Sjogren's syndrome.
Right, because we are looking at a systemic autoimmune condition here.
Systemic being the key word.
Exactly. The patient's immune system isn't just attacking the synovial fluid in their joints. It is actively mounting an assault on the exocrine glands of the body, specifically the moisture-producing glands.
Oh, wow.
This is why these patients also suffer from profoundly dry mouths, a condition called xerostomia, and chronically dry eyes.
Okay, the systemic nature totally makes sense. But the diagnostic procedure the authors showcase feels incredibly counterintuitive to me.
How so?
Well, to confirm this Sjogren's diagnosis, the book shows a sublabial biopsy. There's this photograph of the patient's lower lip pulled down, bearing surgical stitches.
Right, the lip biopsy.
Yeah, but wait, why are we cutting into the inner lip to diagnose a problem that is visibly swelling the parotid glands in the cheeks? Why not just sample the cheek?
What's fascinating here is the underlying mechanism of the disease and the anatomical workaround clinicians use to outsmart it.
Okay, I'm listening.
So Sjogren's syndrome is characterized by systemic lymphocyte infiltration. The body's own white blood cells, specifically T cells and B cells, are erroneously migrating into the salivary glands.
They're invading where they shouldn't be.
Exactly. They crowd the tissue and destroy the acinar cells that actually produce the saliva.
Okay, but if the parotid gland is the primary target of that infiltration, taking a sample directly from the swollen cheek still seems like the most direct route to seeing those rogue white blood cells, doesn't it?
You would think so, but taking a sample from the parotid carries significant anatomical risk.
Oh, because of what's nearby.
Yes. The parotid gland is nestled deep in the cheek, and the facial nerve, cranial nerve 7, which controls literally every muscle of facial expression, runs directly through the substance of that gland.
Oh, geez. So you could hit the nerve.
Exactly. Biopsying the parotid risks paralyzing half of the patient's face.
That's terrifying.
It is. However, the human mouth is lined with hundreds of minor salivary glands, heavily concentrated just millimeters beneath the mucosal surface of the inner lower lip.
Oh, I see. And those minor glands are structurally identical to the major ones?
Yes,
Meaning they are subjected to the exact same systemic autoimmune attack.
precisely. The minor salivary glands serve as a perfectly accessible, low-risk proxy.
That is so clever.
It really is. A clinician can take a tiny snippet of tissue from the inside of the lip, place it under a microscope, and look for those dense clusters of lymphocytes. Finding that infiltration in the lip confirms the diagnosis for the entire system without ever putting the facial nerve in jeopardy.
So you look at the hands to understand the neck, and you cut the lip to protect the face.
Beautifully put.
It demands that an ENT specialist act as a, systemic detective, recognizing that an immune malfunction just does not respect the arbitrary boundaries of medical specialties.
Absolutely. And, Case 85 showed us how an adult immune system can betray them. But sometimes the diagnostic clue isn't a modern malfunction at all.
Right.
It is an ancient architectural flaw. Case 86 forces us to look backward in time to a microscopic construction error that happened before the patient was even born.
Okay, yes, the clinical presentation in Case 86. This is a patient with a painless swelling on the lower neck, featuring a history of recurrent fluid discharge. And the visual pinpoint is highly specific. The opening is at the inferior part of the neck, situated just anterior to the sternocleidomastoid muscle. And the diagnosis here is a branchial fistula, or branchial sinus.
Right. And to understand the mechanism of a branchial fistula, we really have to revisit human embryology.
Let's do it.
During the 4th week of fetal development, the structures of the head and neck begin to form from a series of ridges called branchial arches. And these are separated by grooves known as branchial clefts.
Okay.
As the fetus develops, these structures undergo this incredibly complex process of folding and fusing to create the smooth, continuous contours of the neck.
Here's where it gets really interesting. Because I view this, as an abandoned subway tunnel in a major metropolitan city.
Oh, that's a great way to picture it.
Right. Imagine city planners dug a massive transit tube deep underground, but changed their blueprints halfway through. They were supposed to fill that empty tube with concrete to totally obliterate the pathway, but they missed a section. Decades later, you have this hidden, hollow tunnel weaving beneath the skyscrapers.
Yes, exactly.
A branchial fistula is basically an anatomical pathway that was supposed to be completely obliterated during fetal construction, but a segment was just left behind.
And because it's lined with epithelial cells, which are the same cells that line your skin and secrete fluids, this abandoned tunnel continuously sheds cells and produces mucus.
And it has nowhere to go.
Right. With nowhere for that fluid to go, it eventually tracks to the surface, creating that weeping hole in the patient's neck.
See, my initial thought as a layperson would be to just, put a stitch in the external opening and close it up. Just stop the leak.
I mean, it's a logical first thought,
Oh.
but if we connect this to the bigger picture, the danger of that approach becomes obvious.
Why is it dangerous?
Well, sealing the external opening does not erase the tunnel. The tract remains buried deep inside the neck, continuing to secrete fluid.
Oh no, so it just builds up.
Exactly. It will quickly expand into a massive closed space infection and abscess that will eventually rupture. The only definitive management is the total meticulous surgical excision of the entire tract.
Okay, but wait. If this ghost tunnel was supposed to be obliterated in the womb, where does it actually lead? I'm assuming it doesn't just dead end an inch under the skin.
Far from it. The surgical reality is treacherous.
Treacherous.
Yes. Depending on whether it's an anomaly of the second, third, or fourth branchial cleft, this tunnel weaves deeply into the neck's vital structures.
Wow.
A common second branchial cleft fistula will travel perilously upward,
Yeah.
passing directly between the internal and external carotid arteries.
Wait, really? The carotids?
Yes, the primary vessels supplying blood to the brain and face.
That is insane. The surgeon basically has to dissect an embryological artifact away from the carotid bifurcation just to remove it.
And the tract doesn't stop there.
You're kidding.
Nope. It continues upward, passing over the hypoglossal and glossopharyngeal nerves and eventually terminating on the inside of the throat. It usually anchors in the lower pole of the tonsil, or a small anatomical catch basin in the throat called the piriform fossa. Removing it requires navigating some of the most unforgiving vascular and neurological territory in the human body.
A tiny cellular misfire in the first trimester leads to a high-stakes vascular navigation decades later. That is wild.
It really highlights the stakes.
It does, and we've only unpacked 2 cases in detail. When we zoom out to Section 4 and evaluate the sheer breadth of practice presented in this visual atlas, the diagnostic variety is staggering.
It is. The atlas fundamentally challenges the learner to rapidly switch diagnostic contexts.
Yeah.
Moving seamlessly between anatomical physical exams, advanced neuroimaging, and acute airway management.
So what does this all mean? Let's look at the otology section for a second. The clinician is tasked with interpreting physical hearing assessments, specifically Weber's and Rin's tuning fork tests. And the text doesn't just ask what the test is. It demands you understand the physics of sound transmission through the human skull to differentiate between a mechanical blockage and permanent nerve damage.
And the mechanism behind those tuning fork tests is a beautiful application of physics in medicine.
How does it work?
Well, when a clinician strikes a 512 hertz tuning fork and places the vibrating base firmly on the midline of the patient's forehead, that is the Weber test.
Okay.
Sound waves travel directly through the cranial bones to both inner ears simultaneously, bypassing the ear canals entirely.
Right. And if a patient has a mechanical blockage, like, say, a severe middle ear infection full of fluid or a perforated eardrum, what we call conductive hearing loss, the sound actually lateralizes. It rings louder in the blocked, diseased ear.
Which seems paradoxical
Completely backward.
until you consider the acoustics. In a healthy ear, environmental background noise constantly stimulates the auditory nerve. But a blocked ear is isolated from that ambient noise. So when the pure vibration of the tuning fork is delivered directly to the bone, the blocked ear perceives it as much louder because there's no competing external noise.
Ah, that makes sense.
And the fluid or blockage actually prevents the bone-conducted sound from escaping back out of the ear canal. Conversely, if the patient has sensorineural hearing loss, meaning the auditory nerve itself is dead, the sound will only be heard in the healthy ear, regardless of bone conduction.
And then the textbook forces the learner to apply that understanding of nerve damage to high-stakes imaging. You're presented with an MRI slice of the brain and asked to identify a subtle, glowing mass pressing against the brainstem, an acoustic neuroma or vestibular schwannoma.
And understanding the pathology here requires moving from acoustic physics to cellular biology.
Right.
A vestibular schwannoma is a benign tumor, but benign does not mean harmless.
Definitely not.
It originates from Schwann cells, the cells responsible for producing the myelin sheath that insulates nerves. These cells begin overproliferating specifically on the vestibular portion of the 8th cranial nerve, which is responsible for balance and transmitting sound from the inner ear to the brain.
And because the skull is a rigid, closed box, Any unchecked growth is incredibly dangerous.
Exactly.
The tumor slowly expands within the internal auditory canal, basically crushing the hearing and balance nerves, before spilling out into the cerebellopontine angle, where it begins physically compressing the brainstem and the trigeminal nerve.
Which is why the authors emphasize the use of gadolinium-enhanced MRI for this exact reason.
Why gadolinium
A
specifically?
gadolinium contrast alters the magnetic properties of nearby water molecules. Because the tumor has a rich, abnormal blood supply without a standard blood-brain barrier, it absorbs the contrast and basically lights up brightly on a T1-weighted MRI.
So you can see exactly where it is.
Yes, it allows the clinician to precisely map its margins against the delicate brainstem before taking the patient to the operating room.
That is so precise. And then, from the slow, meticulous mapping of a brain tumor, the text violently shifts gears to acute airway emergencies in the laryngology and rhinology sections.
The pacing is intense.
Yeah, like there is a case involving a 3-week-old infant presenting with stridor. And stridor is that terrifying, high-pitched, turbulent whistling sound that occurs when a patient inhales through a severely narrowed airway.
Airway management in neonates requires an immediate understanding of developmental anatomy. The book presents a case of bilateral choanal atresia, which is a life-threatening congenital condition.
Right. And to understand why it's life-threatening, we have to look at the anatomy of the posterior nasal cavity. The choanae are the two openings at the very back of the nasal passages that connect to the throat.
Yes.
In choanal atresia, a bony or membranous plate just fails to rupture during fetal development, completely blocking that passage.
And the physiological urgency comes from the fact that newborn infants are obligate nasal breathers.
They don't know how to breathe through their mouths yet.
Exactly. Their neurological pathways for coordinating mouth breathing are not fully developed. When they attempt to feed, they cannot breathe through their nose, leading to immediate respiratory distress. They turn blue, cyanosis, and generate that turbulent stridor as they gasp for air.
Terrifying for the parents.
Absolutely. Recognizing the anatomical blockage instantly dictates the intervention, requiring the clinician to secure the airway, often selecting highly specific endotracheal tubes to bypass the obstruction.
So, as a learner, reading through the physics of tuning forks, the MRI contrast dynamics of Schwann cells, and the embryological failures of the pediatric airway, keeping all these disparate mechanisms straight during a chaotic 15-minute patient consultation seems impossible.
It does seem that way. But the initial cognitive overload is a necessary friction in medical education.
How so?
You are not meant to actively reason through the embryology of the branchial cleft every single time you see a neck sinus. You are building visual muscle memory.
You're training the neural network.
Precisely. By systematically working through these 124 image-based cases, cross-referencing the visual presentation with the underlying physiological mechanism, the brain begins to chunk the data.
Right.
The 50th time you see the subtle asymmetry of a parotid swelling, your brain subconsciously flags the pattern, prompting you to ask about joint pain or dry eyes before you have even consciously formulated the Stoegren's hypothesis. This text bridges the gap between conscious deduction and rapid clinical intuition.
It transforms passive memorization into active observational mastery. And speaking of active observation, we promised a clinical review exercise to test your synthesis of the mechanisms we explored today.
Time for the flight simulator.
Exactly. So I want you to step into the clinical flight simulator right now. You are in the examination room. A patient walks in complaining of xerostomia, a chronically dry mouth and severely dry eyes, and you visually note that their parotid glands are bilaterally swollen.
Recall the systemic nature of the pathology we discussed.
Right. Before you reach for an ultrasound or order a CT scan of their face, what part of their body should you ask to examine next? And what specific low-risk diagnostic procedure might you begin prepping them for to confirm the underlying mechanism of their disease?
Give it a thought.
Well, if you mentally reached for the patient's hands to check for the swollen, misaligned joints of rheumatoid arthritis, and you prepped your tray for a sublabial lip biopsy to check the minor salivary glands for systemic lymphocyte infiltration, confirming secondary Sjögren's syndrome.
Then you nailed it.
Yes, you have successfully synthesized the material. You're utilizing a systemic proxy to protect the facial nerve.
Arriving at that answer requires connecting immunology, anatomy, and clinical observation. It's the exact holistic diagnostic thinking this atlas cultivates.
Which brings us to a final provocative thought to leave you with as you continue your studies. We exist in a medical era increasingly dominated by artificial intelligence, algorithmic diagnostics, and honestly, an over-reliance on automated laboratory values.
Very true.
It's dangerously easy to look at a blood test readout, see the flagged markers, and believe you possess the entire clinical picture. Yet, traversing these case studies highlights the enduring, irreplaceable power of the human clinician's trained eye.
Algorithms excel at processing isolated data points. Sure. But clinical medicine is inherently contextual and physical.
Exactly. An AI algorithm might flag an elevated inflammatory marker in a lab report, but it is the human clinician who notices the subtle arthritic swelling of a patient's knuckles as they shake hands in the waiting room.
Right.
It's the human doctor who observes the exact millimeter placement of a pinpoint hole on a patient's neck and recognizes they are looking at an ancient embryological pathway weaving through the carotids.
A machine can't easily do that.
No. A single, highly trained glance, informed by a deep understanding of anatomical mechanisms, can crack a complex case wide open in seconds.
And building that visual muscle memory in the simulator ensures you are ready when you step into the real world.
So keep studying the imagery. Keep asking for the mechanisms behind the symptoms. And most importantly, never stop observing the world with the clinical eye. Because a picture might paint 1,000 words, but knowing the science behind the image is what ultimately saves the patient. Thanks for taking this deep dive with us.